name's Lee Rush, and I have the pleasure of serving as the director of the West Side Heroin Opioid Task Force. We're entering our fourth year. Prevention Partnership is, that's who I work for. We're entering our fourth year as the coordinating agency for this, and this is a real exciting meeting for us. Hello to everybody who's joining us on Facebook Live, and we're also being recorded by CAN TV, and I hear we have WFLD here as well. Both the recordings from CAN TV and Facebook Live, of course, will be available for future viewing, and if you want to share that with your staffs, etc. We don't have a really much time, really, when you start hearing what this conversation is all about. So we're going to move pretty quickly through the intro pieces. I'm waiting. I think the Chief Executive Officer from Lawndale Christian Health Center, James Brooks, is walking up here as a Cubs fan. And, thank you very much. So I'd like to have him come up and welcome you all to this incredible facility and this incredible room. So welcome.
Hello, everyone. My name is James Brooks. I serve as the Chief CEO here at Lawndale Christian Health Center, and it's a delight to have you here. Just a little bit about Lawndale. Our mission is to show and share the love of Jesus by promoting wellness and providing quality and affordable health care to Lawndale and its neighboring communities. So I'm from the community. I live in the community now. This community is dear to my heart, obviously. We are excited to have you here, all our guests from New York. Wow, I heard you went on a tour, and that was great. So thank you so much for being here, and we're honored to be on this journey and to learn from you, because we have some issues here in the city of Chicago, and we got to work together and pull together and make a difference in helping our brothers and sisters. So once again, thank you and welcome to Lawndale. Make yourself at home.
I just want to do a little housekeeping. You've got folders when you came in, and in that we have information on OPSs, overdose prevention centers. In New York, they call it overdose prevention, we call them overdose prevention sites. In New York, they call them overdose prevention centers. You're influencing me. But it's still the same piece, and they'll explain all about it in a bit. But in your folders, there's information again on OPSs, on what harm reduction is, also about fentanyl, which is really driving so many of these overdoses that are happening all over the country. And the main thing we want you to know is, our staff has been passing out, our outreach team has been passing out those blue sheets. We do want to get your survey back on your experience here. We may or may not get to all your questions. If you have questions, I don't know, I think you probably got some little cards to write some down on. We'll collect those. And if you want to put any questions or comments, or we need some more of this kind of things on your blue sheet, please do, because we're going to pull all that together, work with the New York folks and our own perusal of them, and kind of come up with answers for that. I'm not going to introduce other people other than the Chief Behavioral Officer of the state of Illinois, David T. Jones, is going to come up and introduce our speakers. And he and I got a chance to meet when we were visiting back in March, and it was a transformative experience for all of us. And I'm sure you're going to have a great time today. Thanks.
Thanks, Lee. I'd also just want to take just a moment to express some gratitude to, again, Chief CEO Brooks and Lawndale Christian for having us all here. Certainly, we have to acknowledge the wonderful leadership of both Lee and Lou with Prevention Partnership, the West Side Heroin Task Force. Let's put our hands together for that, right? They have been most excellent in reaching out to the community. I'm going to make sure I shout out Miss Gail Richardson, also known as Oprah Renfrew, because they are from and of the community and has certainly been making sure to hear and listen and be the voice. And so we are excited about that. As Lee mentioned, we had an opportunity to go to New York City and visit with Sam and Kaylin and Britt. I think Jason, who did make the trip also, and they just were. So the work that you will hear happening out of the overdose prevention centers in New York City is really next door, right? And so we are so excited for the opportunity for the partnership that is being developed, again, mostly led by Lee and Lou, so that we can have this exchange. And I think this is an opportunity to find out, people who are doing it well, saving lives, and as we have the opportunity to expand harm reduction here in Illinois, we couldn't learn from any better people. And so I am going to turn it over to Sam Rivera, who again is a legend. So I'm going to say this one thing, guys. 100 years from now, when we look back and history is written, one of the people, and it'll be all of his staff, but one of the people who will be acknowledged for having remarkable courage and vision for saving lives is going to be Sam Rivera. You heard it here. Let's put our hands together for OnPoint. And that's it. I'll turn it over to you guys now. Sam, I guess you can introduce the rest of the staff, and I'll hand you the mic. Okay.
Wow. I hope my mom's watching. She's my idol. She was a nurse in New York City hospitals for 40 years, so I learned from the best. So I'll say how you doing, but in New York it just means hello. Don't answer, please. Just say how you doing, that's it. You just nod your head, how you doing back, and we're good. It's truly a pleasure to be here. I'm Sam Rivera, Executive Director of OnPoint NYC. Been doing this work for a little while. So one of the things we wanted to do differently today, I think I'm gonna ask Kaylin to talk about a quick synopsis of what we do and how we do it. Because what we keep hearing is people wanna have a discussion. And that works for us as well. It's very different when you visit us and see what we're doing. Many of you have seen, some of the news pieces and other things that are out there. So what I would like to do is talk about it a little bit, really get into a discussion, talk about how we can support you guys in opening. I want to acknowledge a couple of things first. We have been talking to jurisdictions throughout the country, many, many jurisdictions. Not one jurisdiction has shown up the way Illinois has shown up. So you should give yourselves a round of applause. And I don't say that to put any other jurisdiction down, I really don't. But there's such a vast difference between the way you guys have shown up and the way others have shown up. We've had things that, for those of us in this work, find almost offensive. Just send us your policy and procedure and we're open. This is about human beings, it's about lives. Many of us knew harm reduction, and if we did that without Kaylin, we'd be in trouble today. So I'll end there for now. I'll introduce the amazing Senior Program Director of OnPoint NYC with many, many, many years, more than all of us combined in the work of running OPCs, knowing what they should look like. We had a huge step ahead of people, which is why we're offering our support for others who want to open. So, Kaylin C. No pressure.
I heard from someone in the audience, I think I see her right there. We'll just start from a very depressing place and then we'll go into Chicago and Illinois' hopeful future in this work. But I recently learned that the Cook County morgue is overfull and now using refrigerated trucks for the fentanyl overdose fatalities just in the last 2 days. So this this epidemic, this crisis, as you all know, because you're involved in the effort to address it, is unfortunately just as rampant as ever in your neighborhood, in your community. So overdose prevention sites. The two programs we operate in New York City are, one is located in Harlem and the other is located in Washington Heights. They are built and designed to reflect the very unique community in Harlem and the community in Washington Heights, so they don't look the same. The Harlem community is an older population, many veterans, and it's a high inhalation or smoking population. So they have a large smoking program, a communal smoking room, and the program really reflects their unique needs. Washington Heights is a younger population, encampment-based young folks who are all predominantly speedball injectors, and so the program in Washington Heights reflects their unique needs. This will be the same in Chicago when you start to think through who are we serving and what do they need from us, and the programs will look different based on where you put them and who's there. Our sites are polymodality and poly-substance sites, and that means you can use any substance you want in any quantity you want via any mode of administration. So they're not injection sites. They are injection, smoking, snorting, swallowing, oral administration. You can take your drugs any way that you want. Why do we allow consumption in any quantity? Some people ask us this question all the time. If somebody comes in and we know they have enough fentanyl or heroin with them that we know they're going to overdose, why would you allow them to use it? And the answer is very simple. If we try to deter use in that moment when someone has presented with the intention of use, then we haven't fulfilled our long-term objective of keeping that person safe. So it's really about managing what happens in the aftermath, which is where the magic of the OPC or the OPS, that's where the magic really happens. A couple other unique features of our sites is there's no time limits. The registration and enrollment process is a very, very low barrier. It takes just a few minutes. It's anonymous and confidential. And that's very much by design. And another sort of question we get about that is, well, how do you know that you're enrolling the people that should be using the program and you're not encouraging drug use, and how are you screening out the folks who don't need this kind of program? And we'll talk about that a little bit later, but just know that even now, 9 months in, we are still enrolling existing program participants. So there hasn't been this recruitment from other parts of New York City. We haven't enrolled anyone who isn't an active drug user already. We have over 1,600 active drug users enrolled in both programs. They've been used almost 33,000 times. That's 33,000 instances of public drug use that were picked up out of the public sphere and put down somewhere safe. We've intervened in 434 overdoses, including a few instances of cardiac arrest, and we've only called the ambulance 8 times. That's due to the high level of the training of the staff, and we can talk about that a little bit more as well. Of those 434 overdoses, we've only administered naloxone 86 times, and the vast majority of those administrations were in micro doses. So doses fewer or lower than 4 milligrams. So 1 milligram, 2 at the most. I think I'll leave it there for now, and we'll pass it back to Sam, and then perhaps see if there's any questions that come up. It's very sweaty. Sorry. Just wipe this off for Sam. It's a little sweaty.
Hey. This is harm reduction. It's harm reduction. It's harm reduction. Tissue.
I'm mortified.
It's a microphone.
Oh, God.
We need that clip.
Okay, you
Oh,
are
God.
red.
She's red.
Moving on.
So I didn't get to introduce Britt. I'm sorry about that. We got right into it. But who are you? Say hello. Introduce yourself.
Hi, I'm Britt. Bye. No, I'm the director of operations for OnPoint NYC. That's it.
She'll warm up. She doesn't like public speaking. Yeah, please. Yeah, that's great. Yes.
I will say a total of 3 things in this hour and a half.
But if you talk to her privately, pack a bag. So a couple of things come up as Kaylin was talking, and it's usually what happens with us. I mean, the first thing I thought about, 4:34 when we arrived in Chicago a day and a half ago, we were at 4:15, like overdose interventions. And it's important to talk about a number of elements and how that impacts the community, because people still want to talk about what happens in the room, or the fact that the belief that we're encouraging drug use. Right? People are going to use. Right? People are going to use. We want them to come in and use safely and stay alive. 100%, we get this all the time, especially on my Twitter. Send them to treatment. Send them to detox. 100% of our participants have been to detox and treatment numerous times. And we're not saying it doesn't work, but dead users can't go to detox and treatment. We need them alive. And that's what bothers people mostly, I find. We're loving on people until they're ready to love on themselves. We have to identify why people use. When I ask users, why do you use? Most of them say, I'm lazy, I'm the black sheep, I'm this, and like all these negative things. And when we have a discussion with them about why they're using, what's at the core of their use, is traumatic experiences, pain, mental health. They're self-medicating. It's not all of those other things that society likes to put on them, right? So what happens when they enter our program, not just the OPC, but our program in general, is that they're able to then participate in a human process they're normally not involved in. They're able to make decisions for themselves. We were talking to the students a little while before we started, and the question was about getting people, I gotta get it right, getting people to a place where they can receive help, something like that, to stop using. So I want to say this here. If I offend you, good. If you think, anybody in this room thinks that you stop somebody from using drugs, go see one of those students for a checkup. Because what we do, the best we can do is offer options, offer opportunities. And the person will decide when they're ready. And we want to do everything possible to get them to what's ready. And also, don't put our stuff on them, right? We start from here. We don't go to the root. We start from here. Why are you using? What happened? Why do you still do this? What do you do that? We don't go back. Black and brown people, at least for me when I was growing up, we didn't go to therapy. That's for white people. Therapy means you're crazy. So when you used to talk to us about therapy, we were like, that's for crazy people. I don't go to therapy. So I went to therapy because I was crazy. And that was a joke. You should have laughed or something. So when I went to a therapist and she started asking things about my life, I would always answer from the surface. Why do you do that? Oh, because I'm lazy, or I'm angry. And at the root of it was some deep, deep pain that I couldn't identify with. But she got there with me. And she was able to get me to identify pain that I just put away. And we know that women are better than men at identifying and connecting with that pain and try to work through it. So if we keep treating people from here, we're missing all of the important things that are happening underneath, the root of all this stuff. I was just telling a story to the team here about a situation when I worked in women's prisons, and not understanding why I responded the way I did, but it was my vicarious trauma watching my mom go through it. I'm like, why am I identifying with these women on this trauma? What the hell's going on with me? But it was because I sat as a kid watching my mom go through the same thing. So you're only going to get to that place if we go down in that, go deep into what's happening with them, and not from this place of surface, which is like this quick answer, and you're going to try to fix someone. The other thing I love to point out, and I'll say it, and this is about the work itself. In order to do this work, there's a level of passion you can't teach people. You just can't. And I acknowledge and thank many of you in this room who have gone to some really good institutions and learned a lot and have options to do other things, but choose this work. So I want to acknowledge that, because you have other opportunities. We know that there's a passion associated with saving a user's life that looks very different. It looks very different. It shows up differently. I am blessed. I've been in the organization, June was 2 years. We've had thousands of overdose interventions. I haven't participated in one because I have the greatest. Well, yeah, well, I okay.
Tell them what?
She gonna tell on me. She gonna tell on me. Oh God. Yeah.
You
I participated in one, almost made it worse. We'll talk about that. But no, it's hilarious. The point I was trying to make is they don't need me to participate in them. Right? We have these amazing staff trained by the most amazing staff, trained to respond at the level of an RN, trained to save a life of someone. We had Dr. G in the room during an overdose. And we had to hold her back. She's a doctor, she was ready to go in there and save the day. And she got to see Kaylin and the team respond. And when you have a doctor in the room who sees that and acknowledges it the way you did, it means a lot to us. And I'm gonna stop there and ask Kaylin to tell you my participation in an overdose, because I think it's a good way to talk about how we respond and how not to respond, and what we use and how we use it, and then I maybe open the floor up. But yeah.
It's not very often your boss volunteers for an opportunity to be humiliated, so I'm gonna take it. We as an organization, one of our core values is carving out space to meaningfully employ people who use drugs in salaried positions within our organization. And it's something we're very proud of, but it's not an easy part of the work. It requires a lot of latitude, a lot of grace, a lot of patience, and a lot of love. So we had a staff have a pretty serious overdose, and it was through a series of just coincidences that anyone was in the building when this overdose happened. We were all working late. I was mad at Sam because he was making me be there late, and Sam was mad at someone who scheduled a late call, and it was just this weird sequence of events that we happened to be there. Divine intervention. So we run down to the overdose, and he's very nearly gone. We can't get a pulse. It's full cardiac arrest. It's very, very serious. So we start doing CPR, and we're administering naloxone and doing our best to get him back. And we send Sam to go get us the oxygen tanks, which we need because an opiate overdose is a lack of oxygen to the brain. We've got to get oxygen to the brain very fast. Sam goes running off through the building. I got it, I'll be right back. He comes flying back in with a tank, and it's empty. He brought us an empty oxygen tank. Okay, it's all right. So we go to rescue breathing, and we send him off to get another tank. He's like, sorry team, I'll be right back. I'll just give me 10 seconds. He's running through the building. He brings us a second empty tank. At this point, we very lovingly just told him to sit in the corner, and told him that we'll let him know when his services are required. But just know that it takes a village, even in harm reduction, and good thing some of the other villagers knew where the full tanks were. And he survived. Thank God, the staff person survived, and Sam also survived. He was pretty mortified. So just a little story.
Facebook is cracking.
Yeah.
Oh, Facebook's laughing at me? It was, look, I only knew the 2 tanks I knew were the training tanks. I didn't, anyway, there's no excuse. So now my role is to hold space and be a Native American. So when it's happening, if I'm there, I sit on the ground and just talk to the creator as the team does their work and mind my business. But yeah, that was, and he's one of our best, by far one of our best. Really known in the work, changed his life completely. Since that day, he reports that he hasn't used. And that's not, I will say, it wasn't about almost dying or anything like that. It was just his time. He's been in treatment. He's done all the things. I found out a really good friend of mine was his counselor in treatment 20 years ago. But the thing is, to be ready to treat that individual like a human. And he went to the hospital, and staff went to visit him, and he got himself a nice new ticker. I have an accent a little bit. He got himself a nice ticker, and he's doing well. And it really was amazing that all of us happened to be there that late. And the person that called us was an IT person. And the reason why I bring that up is because in our building and our work at OnPoint NYC, regardless of what you do in your job, you participate in every life we save. Mm-hmm. Doesn't matter what you do. If you're sweeping, if you're inputting data, if you're welcoming people in, you don't have to be in the OPC. to literally save someone's life, to be involved in saving their lives. That's a community. That's community building. I'll talk briefly about what happens in that room. I go to that room 4 or 5 times a day for my own benefit. I don't go there to watch and check on people. I go there to watch and experience a beautiful opportunity, to watch people come in who will often say, because when they come in, we ask them, what are you using, how much? Did you intentionally buy fentanyl? Great question, because then we know. If they didn't, do you know this fentanyl, right? So we can prepare. All that information goes into the room. The perception too is when you open out doors like this, you open up and everybody's just using drugs. Not at all. When you walk in, it's a drop-in center, people on computers, people watching a movie, people having coffee, people eating. She's getting there. People are eating, people are waiting to see a case manager, going upstairs to a holistic health treatment, acupuncture, acupressure, sound therapy, massage therapy, all that love in that building. And in that room, people become a part of a community. And we see people use less simply because they're in a space where they usually use alone and hiding. The shame is gone. I'm a part of a community. They have aspirations. Someone asks, do we talk to them about stopping? We don't have to. Almost every time they come, they talk about stopping one day. Every time. I want to get there. I want to get there. When you're ready, we're ready. See, what most people do in addiction medicine, I want to get there. All right, how do we get you there? Let's go right now. And you scare them, right? Oh, you want detox? Show up at 7 a.m. tomorrow. We've had providers sit at the booth while someone is using, waiting for them to finish to take them to detox. So all of us have to change the way we work. Years ago, that would never happen. Providers say, they're not ready, I'm out of here. But they sit through that moment. I want to share something, add something to what Kaylin said before about 8 calls to 911. In New York City, the average call for an overdose, someone coming in for an overdose, dialing 911, going into the ambulance, going to the ER, on average is $30,000. So we can do some simple math. That gives us 426 no calls to 911 times $30,000. It's a lot of money. That's just 2 communities. You know what it takes us to run both programs? 24 hours a day, 7 days a week, $3 million. So we've saved over $13 million in just 2 small neighborhoods, right, without being open 24 hours. Sometimes it's that simple. We also have community members who are happy. They're not seeing the drug use in the community anymore. They're not seeing the paraphernalia anymore. Their children are back in the parks. This is all factual, right? This is what's happening. And I want to make something else clear. Most of those numbers I'm using are provided by folks who used to use drugs in the same way. Some of the most amazing, beautiful people I've ever met in my life have used drugs most of their lives. Beautiful, hardworking, committed. So it's a blessing to do this work. It's a blessing to show up for people who normally don't experience that. That relationship matters. The ability to be welcomed into a space. The fact that they're used to being thrown out of programs because we tell them how they should show up. Most organizations will use this line. We treat them where they're at. Harm reduction is the epitome of meeting them where they're at. So I'll stop there. If you have anything else you want to add, I think we should open it up and have some fun.
So, Sue Pickett.
I would just say, don't go easy on us. Give us the tough ones.
Anyway, so Sue Pickett was
Can they yell? You're in Chicago, you can yell.
Tech guy.
Ain't the shyest city. Oh, this one?
Okay.
Hello?
I don't know if it works.
Only one at a time? Is that what it is?
Anyway, Sue's gonna come around if you have questions. You might have to shout them out and then use the mic, but raise your hand if you have questions and she can come to you. We're calling it out here, I don't know.
I don't know. All right, Carolyn, go ahead. I don't know if it's gonna work or not. Just stand up. Oh, okay. Hi.
Tell us who you are too.
I'm Carolyn Bloom. I'm the program manager for AIDS Foundation. I run our harm reduction program. My question is, hi. My question is, and I don't think you covered this, how much personal information do people have to share? And is there some hesitancy to share that?
Great question. That's good.
There we go. How much personal information do people have to share, and is there some hesitancy?
Yeah.
Let's turn that one off.
Okay, one at a time. So all of our programs, with the exception of direct clinical care, where perhaps insurance becomes involved, etc., prescriptions need to be issued, are all anonymous and confidential. So to enroll into the OPC specifically, you are asked to provide your anonymous harm reduction program code. You may provide a name if you choose to. If you don't choose to, you can provide a handle, so a nickname. And most of the nicknames are vastly preferred over names, although some people are fine giving their first name. Within your code, your harm reduction program code is usually embedded your date of birth, but once you give it once, it goes away and it never comes up ever again. The reason it's helpful for us to have the date of birth, and you get to authorize us using this or not, so this is a part of patient-directed care, is really if something happens to you and we need to be looking into next of kin, or if we want to follow up with you at the hospital, see if you're okay, and that kind of stuff. It's easier to track people down if you at least have their date of birth. But the person leads that, so if they want us to investigate how they are, if we've had to transfer care to a hospital or something, they let us know if they want us to do that, and if they don't want us to do that, then we don't. So it's a very, very low threshold. Essentially, I could show up and say, my name is Rainbow Bright, and I was born in 1482, and we'd still say, okay, come on in. One thing that is a little bit different, though, is everyone who enrolls into the Overdose Prevention Center is required to sign a consent, a release of liability, and a waiver. And that is the toughest piece of paperwork required to gain entrance to the OPC. It's still only 5 questions, but our staff, we do a lot of training with our staff in sitting with people around that document because it's tough. It asks you to acknowledge that you're there to use drugs. It asks you to acknowledge that your use of drugs could be harmful to you, up to and including your death. It asks you to use that if you're a woman and you're pregnant, that you could be endangering your unborn child. It asks you to acknowledge that in the event of a drug-involved medical emergency, we may have to perform X, Y, Z, 1, 2, 3 on you, and it gives us permission to do that. So it's a bit of there you can see in participants when they enroll a moment of really deciding to do this and to enroll in the program. But our staff, as Sam mentioned, they're just incredibly loving, incredibly kind, compassionate people, really skilled at helping people navigate that particular piece. The rest, as Sam said, is great. What are you going to be using today, and what quantity, and how do you want to use it? That's it.
I have a question. Hello. My name is Claire. I'm with the West Side Heroin Task Force. You gave the pros for the OPS center. What are the bad, if there are any? Because my thought on it at first when it was brought to us, I was like, I don't know, because I'm so used to seeing it, users. Somebody just overdosed in the front of my house this morning, so I'm just so used to helping people and seeing people overdose, and I don't know the effects, so I was kind of in between of like, let's go for the OPS or not. So I was wondering, what would be the bad of it, if there is?
The bad is pretty simple. We don't have enough of them. We don't have enough of them. And you just said why? Someone overdosed in front of your house.
No, I said what I hear you.
Oh, no, I'm just repeating what you said. Right? You said someone overdosed in front of your home. So they should have a place where they can use safely. They should have a place that embraces them. They should have a place where they can be loved on and taken care of, right? We have to, as much as possible, remove the nonsense people have put in our heads, right? That's just what we've received. Someone said, well, they should be on every corner. How about we put one everywhere there's a bar, right? In a liquor store, why don't we do that, right? Because that's okay. The judgment is different. Listen, I said this about acupuncture in the 90s. I'll say it here. And thank you for that. I'm still not over that, that accolade. When America legalizes this, there'll be one everywhere because it means more money. I don't personally at this level get stuck on the motivation. I want people to stay alive. And so if you can see, it's 35 years. These have been running throughout the world. And we just showed up to the party. Because there is not a war on drugs. There is a war on drug users. Let's get that right.
Hi, yeah, 2 questions, if that's okay with everybody. I just want to know, what are the requirements for employment at sites? Are there opportunities intentionally designed to transition participants into paid roles as peers? That's one of the questions. The second one is kind of it's not really connected, but I can ask it now.
Sure.
Or I can wait till you're done. Okay. How intentional is political education for staff as far as intersecting systems of oppression to alleviate the stress of participants that believe obstacles in their lives are of their own making? Obviously, a lot of those obstacles systemic and social. So are staff prepped to have those discussions with participants? Question?
Do you want a job? We like you. We like you. So I'm just going to say this is Kaylin's answer 100%. But I just want to say quickly, staff who work in the OPC have to opt in to work in the OPC. We have not yet hired someone who goes right into the OPC. We've hired harm reduction staff who do other work, harm reduction in other parts of the organization, and eventually, if they're interested, they say they're interested, and I'll ask Kaylin to take it from there. But Kaylin couldn't see you. If you could stand up, she wanted to see you.
Where are you? Oh, there you are. Okay. So the question was, what are the requirements to work for our organization and to transition? Is there a plan or a process for transitioning participants?
That was part of it. I also kind of was interested in if there was like an abstinence-based requirement. In some organizations, they require that regardless of
What services they provide. Like a peer counselor doesn't necessarily have to be abstinent from certain things, but some organizations require that in their hiring practices.
I'm just conscious that Fox News is in the room. I'm straight up about that. No offense.
He's smiling at you.
Yeah, answer it.
My boss says I can answer it, so I'm going to answer it. I'm going to get you. Again, my motive probably was showing into another crew. Anyway, okay. When you come and visit our site, you'll see that there are people who use drugs in various levels throughout the organization who are actively using their drugs of choice throughout their workday with us. We have policies written specifically around maintenance drug use while at work. So philosophically, we don't believe it's ethical or just to ask someone to work in withdrawal or to put people in a situation where for any reason they may feel they're forced to conceal their use. However, we got work to do, and we got to be able to do it properly. So it's not a free-for-all. But what the magic is that we've created a space where we can teach people how to practice maintenance use, and we can do so over time with supports in place, because learning how to have a job and manage your drug use with folks is sometimes a bit of a process. And within our organization, there's latitude to figure that out. However, we believe that the respect and inviting people back into society, inviting people who use drugs back into society, if we're gonna do it, we gotta do it, right? Which means giving people who use drugs good salaries, giving them jobs, putting them into decision-making positions, and holding them accountable to the duties of their role, because that is the respectful thing to do. Your drug use is a piece of who you are, it's not the only thing about you. And I think that's where the organization feels unique. So I don't think there's really a department where if we found out you were using drugs, we could say, this isn't a role where you can be using drugs. It really is throughout the organization, and it ebbs and flows over time. There have been years when easily 30 to 40% of our staff were using in some way, and then there are other years where it's lower, higher, etc. In terms of participants and an entryway for participants into employment, that happens all the time. I think a very high percent of our harm reduction specialists, that's an employment category. Our outreach and public safety team, that's an employment category. Many of those folks are recruited from our participant base, and I don't know if I can share this, but I think it's important. Our entry level salary is healthy, and that's intentional. It's a living wage.
Yeah, thank you for that question. I want to add something too. Since we opened the OPCs 8.5 months ago, we hired at least 10 participants specifically who use the OPCs, who have worked for us. I think we still have 8 with us, or 6 or 7 with us still. And that's the other thing we talk about when you hire folks in the community and you give them opportunities. You have to remain fluid and understand that they might have their struggles. But I want to say something quickly before we take the next question. How many people who work in these abstinence-based jobs or organizations or whatever ever sat next to someone on Monday morning and they smell like alcohol? Yeah, okay. Hold that.
Okay, hi, I'm Chelsea. Sam,
Hey.
you and I were texting yesterday.
Oh, that's you.
It's me.
Hey.
And yesterday at the Harm Reduction Summit, you were talking about the crack house statute.
Yes.
So I'm a part of a collective of people, some who may be here, some who may not be here, who are working on legislation to legalize at a pilot level the Chicago-based overdose prevention site. And I'm wondering, from your perspective, if you have any advice for us in terms of, helpability with being able to actually do this, and if you were involved in the legal process for allowing you all to do what you do and how that works and all that good stuff. Okay, done.
Man, we should have kept texting. So the crack house statute created by Joe Biden. That was funny. That was really good. Nice try, damn it. Not gonna get me, I don't need a microphone. Joe Biden created the crack house statute. If you look it up and you watch the video, a couple of times he says it with such pride. Right? Crack house statute prevents us from doing what we're actually doing. It makes it illegal. It makes it illegal to fund us, which is why we're broke right now, quite frankly. So we cannot receive funding from city, state, federal dollars. So I love when people tweet at me and say, you're letting those drug users use your space for our tax money. No, it's not yours. Good try. We don't use a dime of your money. We cannot. I would love to use your money. But the crack house statute prevents that. So I keep reminding Mr. Biden, where's that camera? Mr. Biden? We live in America, where there's a great place for second chances, and we want to give you a second chance. Right? We want to give you a second chance to wake up and repeal the crack house statute. It's a mistake. And as I said numerous times, I'll say it again, and I just said it to Governor Newsom in California. If you have the power to sign a bill or change something that allows OPSs, OPCs, safe consumption sites, whatever you want to call them, don't call them injection sites, to exist, and you do not, then you're participating in the loss of life of drug users. That is not negotiable or debatable. You have the power and authority to do it, you choose not to. You're saying they're less than? You're saying you don't care about those lives? Because what we've heard is, wow, the community is cleaner. What happened to all those lines of drug dealers that were going to show up to the front of your building? Not one, right? My favorite compliment, and I'm thinking about getting it tattooed on me, is, wow, I forgot you were open. That hits me deep. They forgot we were open, right? Because all of these things people made up in their heads just aren't true. They're not true. About a pilot is a very intelligent way, brilliant way to get around some of this stuff. And you're smiling, so you know, right? And it's an opportunity, it's an option. We don't want to do it now because we opened already. That was going to be my last resort, right? If we didn't open yet, then I would go to the governor and say, give me a pilot right away. We don't want a pilot. In New York, we don't want a pilot because we're open. But a pilot is a very good strategy for opening one in a state where you don't have one yet. It keeps a lot of people safe, unlike me right now. Any attorneys here? I like attorneys these days. Because according to Biden and his crack-out statute, I am currently committing a crime that carries a 25 to life sentence by operating, probably 50 now, 2 of them, 2 sites, which is considered federally illegal, right? So we should talk a lot more, keep texting, and figure out ways to support you through this. I'll say this too. You guys have an opioid settlement board, right? Do everything to participate. Send as many questions, show up, ask to be a part of it. If you're not at the table, you're likely to be on the menu. Show up. Don't let them run this without you, right? I hear that in this state, you have to pay for your own syringes. If you're not at that table talking about it, then you're losing an opportunity. So show up, be there, be strategic. As I said before, no jurisdiction, no state or city has shown up like Illinois. Does anybody know what Illinois means in your Native American language? Oh, I'm gonna cry. Do you know who the Native Americans are of this land? Don't take your phone and Google. It means warrior. Yeah, be a warrior. Don't be a worrier. Be a warrior. Yes.
We have a question from the audience.
Oh, yes.
Hi, thank you. Laura Garcia, Director for the Division of Substance Use Prevention and Recovery for the Department of Human Services. First of all, thank you for showing up for Illinois as well, because we are learning from you and we are really excited to continue the conversation. If possible, can you talk about 2 things? 1, your relationship with law enforcement after you opened, and 2, the impact to the family and the communities, because let's be honest, we have family members seeing their loved ones used at home, overdose in front of them with no resources. If you could talk about that point, that would be great.
Sure, I'll share that. First question with Caitlin. So before we opened, we were negotiating back and forth. Caitlin wouldn't let go of this one thing. We were getting letters. We wanted to get written support. We were taking risks. And we wanted to get the commissioner of the police department to sign off, and it was like not happening. So we were worried because, law enforcement really can shut it down right away on the ground. And so that situation went from, it's not going to happen. Then, we had to back up a little bit and understand that commissioner is for all the precincts in the entire city. And we're opening in 2 locations. So making that broad statement is a bit out there. The strategy has to start from where you guys already have, which is your DA signed off to support this. That starts to get law enforcement to wake up. Because what that means to law enforcement is if they make an arrest, the DA already told you, I'm not going to prosecute. So now where do we meet in the middle? So we step in. The harm reduction organization steps in and says, this is where we show up. We're providing this service. We want to partner with you in these 2 locations. And I want to tell you, one of the best it's so hard to say it almost. Where's Fox now? One of the best partners, Kaylin scared them away. One of the most important and best partners we have at these 2 locations is the NYPD. No lie. Completely beautiful. Kayla and I receive text weekly, sometimes daily, from commanding officers. Our staff has shown up to their roll calls to talk about what we're doing, how we're doing it. Many of the police have shown up to visit the site. Also changes the dynamic with the participants. Many of you in this room are saying, wait a minute, you let people come in with uniforms? And yeah, we tell the participants, they're coming in there with me. You talked about hesitance and trust. We would bring anybody in that room, and the participants, if they're bringing them in, I trust them. And it's important, right? So we're coming in with white shirts. I don't know if that makes sense here, but beat cops coming in, visiting, spending time with us into those rooms. And then, well, you should talk about what they asked us to create for them in these palm cards, the impact it's having. I'll just share that on a few occasions I was coming into the office and I saw an officer walking with a participant and I ran over to save the day, and I was wrong because they were escorting the participant to our site. When they used to go up to them and frisk them and arrest them, now they're walking them over to our site so they can use safely and stay alive, have a meal, have a shower, wash their clothes, receive loving services as they deserve.
The fentanyl concentration in New York City was between 3 and 9% for the last year or so. In the last month, Sam and I started to get text messages from the precinct captain of the 2-5 in one of our neighborhoods saying, my officers are freaking out, people are going down all over the neighborhood, we have 5 DOA in Marcus Garvey Park, what are you seeing in the sites? And we said, we need more information, I need to know time of day, I need to know intersections where you're finding people. Can you get me this? And he said, yeah, absolutely, we'll gather this information. This is the captain at a precinct. Meanwhile, we went back and we started pulling samples directly out of the OPC and went to Marcus Garvey and collected samples from the park, and we started running them through our spectrometer. And we were able to see that the concentration in the fentanyl supply, or in the drug supply, had jumped from 3 to 9 to 15 to 20% concentration, which is more than enough of a jump to account for those fatalities. We got back to the captain of the 25th precinct and we said, this is what we're seeing. We have a theory that this is probably not the injectors, probably your 5 fatalities were smokers. That's my theory. And he said, you're right. And it was the relationship between the consumption site and the precinct that catalyzed an immediate response to a spike in the purity of the fentanyl in the drug supply. We opened our program 4 hours earlier. They dispatched more officers into the community with Narcan, but it was that coordinated effort between us and the NYPD that resulted in a real in helping to protect people through this surge in purity in the drug supply. They also said, because they are police, this is the NYPD, we had just come through Black Lives Matter, George Floyd, Eric Garner, and there was no love to the NYPD in the city, especially in the neighborhoods where we operate. And they knew that their trust was low, so they asked us to create a card so that when they were working with a street level person who uses drugs, they could say, listen, we're with OnPoint, we're on that team, you can come with us, we're not going to arrest you, we're going to bring you back to the program site. We've also had instances where an arrest could not be avoided, so for some other crime, usually not low-level sales or consumption charges, possession, where NYPD officers have brought the person to one of our consumption sites before they take them into booking. So they can eat, so they can shower, so they can use, so that they're not sick in holding for when they're processed. And if even as I'm saying it, we are so indebted to them for when we had that conversation, what they said to us, and I really hope that Chicago PD says the same to you. We don't really understand it, but how do you want us to interact with the site? It was coming from an information gathering perspective, and our response was, listen, it's New York City. You have a community policing responsibility in the neighborhoods where we operate. It's not that we don't want to see you. Keep doing your job. All we want from you is help us ensure the sites are a success, and if people are scared to use them, they won't be a success. And they understood that completely. The other thing we said to them is, we're going to do our very best to not call you, but if we do, it's because we really need you. And they've been absolutely exceptional throughout this entire process. Families, can I, yeah, well, all right, let's clap for them. They get no love. Families, I'll pass this back to Sam. The families of the people who we work with are very different person to person. We have some folks who have no connection to their family whatsoever. And then we have the other side of the spectrum where the families are still very involved. What I will say is that the sites provide a level of comfort to a lot of the families of our folks. So we have people who use our sites who take pictures of themselves in the site, in the booth, and text it to their families, and that's how they show their families that they're alive and they're safe. And that happens a lot. We have families who drop off Christmas cards and care packages for their loved ones because this is the only place where they know at some point their loved one is going to touch down. And that's an incredible responsibility for the program, but it's also one of the most beautiful parts of the work, is that through these sites and through the stabilization that comes when someone engages with the site regularly, we're really seeing a rebrokering of relationships that previously had been really fractured and really tense. So these sites are reconnecting people to their families and providing a measure of comfort to those worried parents and worried siblings, etc. on the other side.
Yeah.
Illinois has some really harmful child welfare practices and policies. So I'm curious if you've had experience with navigating that system. You know, I'm thinking about all the different kinds of folks we would like to be present for participants. You know, domestic violence advocates and those folks who are all, you know, considered mandated reporters and how harmful that can be for the participants using the program. So I just would love to hear lessons learned that you have.
Yeah, that's a doozy. So we have policies and procedures around pregnant and parenting people who use drugs, and we have pregnant and parenting people who use drugs who access our sites. I don't know that we have time to go into the full meat of the policy, but the core of the policy is, again, kind of that foundational sort of tenet that your drug use is a part of you. It's not your whole being, and that you are still, there is very much the opportunity for you to be an exceptional parent or caregiver, and also be someone who happens to use drugs. For us, very simply though, it really requires for planful consideration for the needs of the most vulnerable person in the dyad, and that is never the person who uses drugs. It's the dependent. So it's structured, it's transparent, it's a very raw and honest sort of policy that says, listen, if you're going to do this, we have expectations of you. And we're here for you, but we're going to hold you accountable. So not everyone who works on our staff is a mandated reporter, and the people who work in the OPCs generally, this is not across the board, but a lot of them are not. Having said that, if somebody is touching down in our OPC, because the OPCs are so good at what they do, 80% of the people who have enrolled in our program have been connected into other care directly from the OPCs. And this is a population that wasn't connected to nothing before the OPCs. So that it's very likely they could be touching down with a mandated reporter in another arm or program within the organization. But in a similar fashion to the way we work with people who use drugs who hold employment positions, it's the same with a pregnant or parenting person who uses drugs. So it's a supportive-based learning to manage the two priorities, always in favor of the needs of the most vulnerable person in the dyad, which is usually the dependent. One thing I will say is since launching the OPCs, we have had 2 babies come up through the OPCs and were delivered, were not taken away by ACS. It worked. Both mamas still have their babies. We see the babies all the time. They are healthy, they are so fat, they are so cute. And the families are doing really well. And I know it seems counterintuitive to keep a family together using an overdose prevention site, but the only reason these mamas made it to term and had the birthing experience that they did and were able to keep their children was because of the OPCs.
Would you describe, so this is David C. Jones, Chief Behavioral Health Officer for the state of Illinois. If you guys could describe the environments of which your OPCs are located and what's in close proximity to those OPCs.
He wants to talk about the school.
David, I know exactly what you're getting at.
That famous photo. Like, why is he posing like that? And now we know. Okay, Fox is gone.
Fox is gone.
So directly across the street from our Harlem site is a daycare center, a huge one.
No, across the street,
Yeah,
y'all.
like
they face each
yeah,
other.
Like we wave at them.
Every day.
It's powerful, really powerful. Of course, before we opened, we went back in there, talked to them again. They're like, why are you talking to us? We're cool, it's good. You know what you're doing, we trust you. And I wanted to go there because I knew the news would do what the news does. So we wanted to give them a heads up because none of us were ready. Kaylin kept telling us, be ready. And when we opened, the news was just, it was wild. It was wild. I want to talk about 2 quick things. 2 things about protesters. There were all these protesters. No. There was a protest in Harlem about the oversaturation of treatment programs. We're not a treatment program. They didn't know any better. They're like, well, let's go by their office. Maybe we did have one protest, 4 people and a dog.
A very small dog.
And the dog was tiny, but the dog was the loudest one.
And he was asleep.
And he was asleep. Yeah, we had to give him some water, wake him up. But the reason why also there's something we tend to forget to talk about. I want to say quickly. We have a media consultant. It's one of the best and smartest things we did to open these sites. You need one. You better get one. You heard. You better get
She'll
one.
be handing out her cards.
I'm telling you, because there's no way you can manage what's going to come. There's no way. But one of the reasons why I brought it up too is about the school across the street and all that. The reason why I wanted to talk to them and talk to the executive director is to prepare for the stories. And the stories came out. Mm-hmm. Look at this, and there's people shooting up in front of the school, lie. And every time the stories come out, I like to tell the news folks that someone who uses drugs doesn't identify who they are, right? It's one part of who they are. It's not who they are. And my mentor, David Rothenberg, who opened an organization called the Fortune Society in New York, always reminded me of a story we had years ago where we had this writer, this news reporter who wanted to keep identifying people by the worst thing they did. The drug user, the prisoner, the murderer. So we asked him, were you ever like a bedwetter? Because then I want to see you write the article and say, the prisoner, whatever, written by bedwetter Tom, right? Because if you're going to identify yourself by the worst thing you've ever done, I love to see that all come on. Let's take these stickers off and write down the worst thing you've ever done and put it on yourself. We can have fun, right? That's power. There's power in that. There's oppression in that, right? This is how they keep black and brown and what poor white folks oppressed, by doing things like that, and we participate in it. So we have to watch that stuff. Don't participate also even in the work you do, in the language. I find people who look like me talking worse about people who look like me. Participating in the oppressor's way. I'm a Native American. Don't ever ask me where I come from. ever. Don't you dare, right? So, but we participate in that, right? I'm a Native American, but as cool as we are, we're not this dark. So I identify as Afro-Taino, because I'm African as well. We've been taught to separate those. What's different about us? What we do in our work is primarily focus on what do we have in common. What do we have in common? What are we trying to achieve? So at the school across the street and with the other programs and apartment buildings is what are we trying to achieve? When we opened and the community said, why did you do this? I said, I responded to your request. And I don't know where it came from, but it was a good one. It was fast in the moment. And they were like, what? We didn't make a request. I said, oh, but you did. You said you didn't want drug use in the street. You said you didn't want paraphernalia in front of your schools. You said you didn't want drug users in the public bathrooms or restaurants or in the alleys. And we were courageous enough to bring them in. And take all that away from you, perfect people. And they can do it with us. And they don't know what to say to that. That was your request. What I didn't mention is within that request, they often say put them in prison or jail, get rid of them. We'll take them. The last thing I'll say about that, I think Britt wanted to add something, is one of my new favorite ones is if you have children, maybe some of you watch it anyway, you could say you have children or you watch it with your niece or nephew. I like that excuse.
That's me.
What's the name of that movie? Encanto.
Oh.
Encanto. Let me show that I speak a little bit of Spanglish. Encanto. We want Bruno.
Oh, I love it.
Right? In the movie they talk about, and this is what we do, seriously, as black and brown folk. Right? We had the crazy uncle, right? Put him over there. We want those, bring them. We talk about Bruno. We want Bruno. I'm actually gonna start a program, something with, I'll figure it out. An intervention, maybe it's an intervention about Bruno. But it's really about us taking on people that others don't want to deal with. They just see them as disposable. We see them as lovable human beings, right? Who mean something. So that's what, when we give the definition of harm reduction, it's kind of long for that reason. So did you want to add something?
Super quick. About this school across the street. When we first opened, there were a couple of community members who came in on a Thursday demanding for a tour to see the OPC, and they said, we're part of the school across the street and the parents are pissed and everybody's pissed and I'm pissed and you're stupid and blah, blah, blah. And so it was just a really powerful thing for me to be able to say, oh, you're from the school across, who are you? Because we had a meeting with the staff on Tuesday. And the community members didn't know what to say because obviously they were BSing us, right? They weren't part of the school, but it was really wonderful. It's really wonderful, the relationships that we've been able to build with community members, even the community members who you would think would be protesters or dissenters. And it's a testament to the work that we do. And across the street from our other location, Washington Heights, is a playground, right? So we love the kids here, apparently.
Well, I gotta talk about Washington Heights.
Yeah,
I gotta talk about the Heights.
I'll give it to Kaylin, but that playground is usable for the first time in years because we opened. So bringing spaces like this into communities doesn't make the community worse. It truly does make the community so much better.
Yeah, I'm just gonna build on that. So in Washington Heights, before we had the OPC, I and one of my colleagues, Adrian, we were going to community board meetings and build the block meetings at our local precincts, trying to help the community understand what harm reduction was. This was pre-OPC. And we were invited to this community meeting and we showed up and it was absolutely packed to the rafters and people were really pissed. And Adrian and I looked at each other and I was like, this is not gonna be good, man. And they were there because, I don't even know if I've told you this, Sam, a 4-year-old girl had picked up a syringe and put it through her cheek. And they wanted answers from us, like they were out for blood, like off of their head. And we survived that meeting, but this was like people throwing stuff at us and very, very, very charged. So we were invited to make a presentation to the community board because it was agreed that we needed more understanding for harm reduction and how it worked, etc. And we also really needed solutions to the public drug use and syringe litter issues that were happening in the neighborhood, clearly. So Adrian and I show up at this community meeting with our presentation and our raincoats on, because God knows what they were going to throw at us this time. And the room was full of like school kids. And we were like, what's this? What's going on here? And up go the Wheels Academy children who do their beautiful presentation about how the public drug use and the syringes are impacting their ability to get an education in Washington Heights. And people are crying, and they get a standing ovation, and another standing ovation, and Adrian and I are just like, oh God, we have to go after these kids. So the only thing we could think of to do in the moment, we didn't even bother doing the presentation, was to just say the only way we can get through this is we have to partner with the school. And this was an elementary school. So we're on 180th Street. On 182nd, it's called the 182nd School Corridor. There are 7 schools along that corridor, all the way up from pre-K to high school. So we built relationships with all of the schools along that corridor, knowing that we had Fox is gone. We had an unsanctioned overdose prevention program operating in Washington Heights because the fatalities were happening all the time. And we relationship built with each one of those schools. We now host internships for those schools at our programs. We partner on a community garden. We did Clean Air, Green Space Initiative. We are the only harm reduction program that we know of who is directly partnering with schools in our neighborhood to address the issues that are happening. They went from literally throwing chairs at our heads to being the first people who will stand up and say, we absolutely know what they're doing. They're instrumental to the way our learning communities understand the opioid epidemic and what's happening in our neighborhoods, and they defend us to the hilt. So, okay. Yeah, thank you. Britt also mentioned when you open your OPSs, your outward-facing work that you do in the community is more important than anything you do in the building itself. So we have 3 outreach and public safety teams that work in the 3 neighborhoods where we operate. Harlem, so a dedicated Harlem team, a Washington Heights team, and a Bronx team. Their entire job is to reframe the issue with every angry community member, every business who doesn't understand what you're doing there, every faith-based leader, every principal, every bus driver, every postal worker, every pharmacist, every CBO, everyone. Because we open these sites for 2 stakeholders, the participants that use our sites and the community members in the neighborhoods where they operate. And you have to make sure that your communities know that. A well-run site will integrate so well into the tapestry of the neighborhood, just like Sam said, people will forget it's there. And that journey is not always an easy one, as I've just illustrated, but I wanted to tell that story because you can get there. But it is about relationship building. It's about being brave enough to invite people in and show them the work you're doing, because it will work. If the work is solid, they'll be behind you 100%.
Hi, my name is Katie Proud, and I'm a writer with the Chicago Reader, which is our village voice, RIP. And I have a question about, speaking of media coverage for these kinds of stories, what questions do you wish that you got asked that you don't often get asked? And who are we leaving out in our coverage? Whose voices and perspectives do you think are underreported? Thanks.
Did you hear the other half of that question?
I didn't hear the second half. What was that?
Whose voices have been left out of the conversation and whose voices have been underrepresented?
So I don't think it's about questions that haven't been asked. I think it's about questions that have been asked and not printed.
That's
right?
facts.
Or not shared. No one has yet, at least I don't think so. Not one person talked about Biden and the Krakow statute. Maybe you could be the first.
Maybe I
You
will.
know, every time I bring it up, so I'm gonna get a T-shirt and just keep talking about it. I'm gonna tweet it all the time. I don't really understand it. I don't understand the fear. I don't understand it. I talk about that every interview, and it almost never comes up. I think maybe at a couple of them, but definitely not on print. Very few people write about it, and that's the answer, right? I think people have asked some really, really good questions, but don't always put them out there. You know, we meet with a camera crew for 2 or 3 hours, and it's a 3-minute piece. You know, that's why we tell most people some of the best ones to watch is the 13-minute doc with invisible people. You can find it on YouTube. The I'm on Poor piece, where I was really on that day, I would say.
He cried a little bit.
I cried a little bit. But, you know, it's so yeah, it's not really the questions more than what's actually coming out, you know. And the second piece, whose voices?
Yeah, who are we not talking to?
Well, we're talking to the wrong community members. It feels so fake. It's so fake. And I mean, no, I shouldn't say, that's the other guy's word. It feels so staged. Stage is better? Right, thank you. Woo!
Communications gave you.
Yeah, communicate. I'll talk to you.
Let me get over it.
So it really feels staged, because I'll give you an example. We know the community, and they'll say, hey, I'm talking to Mary over here. Oh, Mary. I'm talking to Barbara, and she's telling me her grandmother, because since they opened, her grandmother can't walk on this block. Your grandmother hasn't walked on a block in 30 years, girl. Stop. It ain't because we open. Stop. But that weird positioning and that dramatic nonsense, like, again, man, we're talking about human lives. Let's not play around with this, please. You want to do that about somebody wants to open a porn store or whatever the hell, something like that, another liquor store, those don't have attention, right? But the staged nonsense, the questions asked, and then people like to be on film, right? Like, oh, I'm gonna be in the news, I'm gonna say whatever this guy's asking. And they're also presented in a way just to create a negative dialogue, right? And it's just not real. It just isn't. So I think we've had a fair share of good questions and insight, but it just doesn't show up. Mm-hmm. And that's painful.
Can I talk?
Yeah.
Piggybacking on what Sam was discussing when he was talking about the news trying to get the other side, we've heard those words come out frequently. There was a community organization in one of our communities that started out not liking us at all. And what do? We brought them in, we gave them compassion, we said, we understand why you're concerned, we understand that you don't know what we're doing, let's educate you. And they became one of our strongest supporters. And we were on a call with them and they said, I am so sick of the news calling us to get the other side. Mm-hmm. We don't want to be the other side anymore. And they actually want to work with us and be in a news piece together, but not as the other side. So that's something really important as you are thinking about writing news stories, is not to always look for the negative. Look for the positive. It's out there. So many community members love what we do. So.
Yeah, you know what? I did miss one. Oftentimes when they try to get the other side, they're talking to a gentrifier who came into a black and brown neighborhood and are trying to lead the way.
That's right. Savior.
The savior. They're going to try to lead the way. They're going to try to tell black and brown people what they need in their neighborhoods. My first meeting with the concerned folks in Harlem was an Asian woman, a white man, and a white woman. And I'm like, what part of Harlem did you grow up in?
Right.
But it's real. And when I say you shouldn't see, here's the thing. I'll speak for me. I don't want any more white allies. I want white accomplice. Right? Get down with me. Don't cheer me from over there. Hey, Sam, where to go? I got your back. From down the street. An accomplice, like some folks sitting here, are gonna sit with you and say, let's do this together. Let's share these handcuffs if they come out. Right? Language matters. No more allies. I mean, we have some allies, but they just clap from distance. You know, they don't really show up. So that's the voice that's missing. Talk to someone who's been there a while. Talk to someone who's been there a while and also is also aware, because that's the other move they do. They interview an old woman who's been in the neighborhood a long time. She's been complaining about the neighborhood for 50 years. It's not about us. We just opened last week, right? Yeah, this neighborhood is stuff. No, it's not us. We just got here. And then the other side is, I love this one when we open, right? We don't want new stuff. We agree. We've been here 30 years. No more new stuff. Next. Got to be ready. We got to be ready. The thing is, this is our fight. This is our fight. If you don't want to be in it, just leave. Please, let us get down. Right? This is our fight. You know, if you're not going to participate, just like keep it moving. Go fight about something else. Go somewhere else that matters. And if you're going to show up to a fight with me, don't bring a knife. It's not enough. Don't bring a knife. Right? Ever heard that statement? They brought a knife to a gunfight? Don't bring a knife. Yes.
Are you behaving?
I'm behaving.
Hey, it's Tim Deck with the West Side Opioid Task Force, and over the last couple of years at least, there's been some focus groups in the community where the OPSs will operate and with different stakeholders, police, drug users, community members, treatment providers, business owners. I remember from the stakeholder group of community members, neighbors, people who live in the community, there was some feedback about making the OPS sites be more than just a site, a place where people can use drugs, but also offering supports and services. And you talked about a little bit of that, like with I heard you reference outreach, showers. Can you talk a little bit more about what all you do and how you do it alone?
Thank you. Well, I'm gonna hand this over to Kaylin. Because what I want to say is, as folks, I'll repeat what other people say, it's hard to call ourselves like the leaders in this, it feels pompous. But as folks being asked to support other jurisdictions and organizations in opening, we're basically demanding that you have wraparound services. We had people, when they finally agreed on what we were doing in New York, say, okay, we really agree, but can you open it under that basement, under that bridge over there where no one sees it? But then those same people will say, see, all they're doing is letting them use in there. They're not connecting them to things. Kaylin said, if you didn't catch it, 80% of the people, of the 16, almost 1,700 people who have used these services have utilized other services in the organization. 80%. There's no more, I mean, we just walked through this place. Oh my, there's nothing missing here. I was just waiting for a movie and a massage. Like, this is way beyond. You don't need all of this, but bless you. This is beautiful. You got me in trouble though. They're gonna yell at me on the way back. We don't have enough. This is beyond, right? But there's a minimum standard, and I'm gonna ask Kaylin to talk about that. And we're not done. We're still growing, and walking through here has given us some inspiration on adding other things, right? We just don't have the space in New York, that's for sure. But thank you for that question, because Kaylin will talk about so many things people do in the building, and there's an advantage, and you might have said it last night. Then when people enter, they don't know what they're entering the building for. And there's a benefit to that. I've done HIV/AIDS work for many, many years. And I would talk to organizations to take that name, AIDS and HIV, out of their program, because when you call someone's home and call ID, HIV something or AIDS something. Same thing in entering the building. If I'm entering the building for a service and it says the service, the number one service they provide, sometimes, HIV, we're in a very different place today, but sometimes it talks negatively, right? So if someone can enter a building and have 20 different things to do in that building, it does impact stigma in that way.
Yeah, okay. That was quite a setup. Okay, a couple things. One, fact. If people have nowhere to be, they have nowhere to be. That's just a fact. Two, there's a criticism of safer consumption sites, and it's really the only criticism that I think there's any scientific evidence to back it up. And it's that everyone in the safer consumption community for the last 36 years, we all jump up and down and wave our arms around and say, no one has ever died in a safer consumption site in 36 years. And while that's true, the criticism is, yeah, but you're also concerned with numbers, how many people that you've served. You are discharging people post-overdose intervention, and then the naloxone is wearing off and they're dying outside. So they're not technically passing away in the consumption sites, but you're churning them out the door, and then the overdoses are coming back, and then the naloxone wears off, and they're passing away in community. And there is some evidence to support that that is sometimes true in some of the other jurisdictions around the world. So co-location, 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 co-location. Our OPCs are one program of many in the same building, and the programs are all operated by us. So what do we know about people who use drugs? Harm reduction programs do the best they can to take care of people who use drugs in their programs, but of course they have other needs, and so I'm going to try to connect you to a provider who is going to help you with your mental health care or your housing or your medical care, but they're not a harm reduction provider, and that's where it all falls apart, right? We see that all the time, yeah? And it's really heartbreaking because we've been trying to build trust with that person who uses drugs in our harm reduction agency. They finally trust us, we're finally going to do this. They're treated like garbage wherever we refer them, and it's now my relationship with them is jeopardized. So what OnPoint is trying to do, and what we're encouraging other jurisdictions to do in whatever way they can, this can look so many different ways, is to really create spaces for people to be. So we have two buildings, one in Washington Heights, one in Harlem, and we are giving the building back over to participants so they can move throughout the building and throughout the other programs as they need. So there's the OPC, there's the lounge, which is like the living room, right? So it really feels like a lounge. You don't have to do anything in there but watch Seinfeld and drink coffee if you want. There's free showers. There's a drop-off, wash and fold laundry service. So while you're in the OPC, or maybe you're visiting with the nurse, you can drop off, you can say, today I want lavender scented. You can come back and get your laundry all folded up nice for you, because this population never gets choice. So it's giving choice back, because choice is agency. I have agency, I'm a person in the world, I should be able to make choices for myself. Our drug user health hub is staffed by some of the most badass harm reduction medicine providers you'll ever find who understand harm reduction medicine, because harm reduction medicine is different than addiction medicine. And our medical clinic is attached to a garden. So if you want to see the doctor sitting in the garden smoking a joint, because that's legal in New York, you can do that and do a medical service that way. If you want the doctor or the nurse to visit you in the OPC while you're using the booth, and that's where you're going to do your doctor's appointment, great. If you're a person who uses drugs and you need to sleep, and I know this is true in Chicago because we've talked about it with our hosts here, people who use drugs are not allowed in the shelter system here, right? So we have respite rooms, whereas a person who uses drugs, you can go up and you can have a nap. They got sound machines, aromatherapy, because some of those feet get a little right, right? They're supported by CBD and THC. They have heating pads, hot water bottles, little stars. But it's a room for people who use drugs. We got a holistic room where you get acupuncture, acupressure, sound therapy, massage. Imagine that you have an overdose, and you're used to having an overdose in a crappy, dirty, disgusting, rat-infested New York City subway station. But now you're having an overdose with our loving staff in our OPC, and you're taken up to our holistic room to recover from your overdose while getting acupuncture. Like, what a life. Everything in our program spaces are meant to tell you that your life has value, and that you matter, and that everything that you do, every choice that you make, can be your choice. You're not forced into a variety of kind of programs that aren't really designed with you in mind. So really patient-directed programs for people who use drugs. Volunteer programs, all kinds of groups, and not just those health-focused groups. We definitely have those. We're not immune to those. You know, we gotta do those, the buprenorphine group and the Seeking Safety. We have all that stuff. But we also have jam sessions and open mics and Vogue groups, and just recreational-based fun stuff, African drum groups, you name it, barbecues, all that kind of stuff as well. All of that is located in the same building. Last thing I'll say, we also have something called the Harm Reduction Mental Health Unit, and it's very new, and it's growing, and it's finding its feet, but we're excited about it. And we've hired social workers who understand that there's a wall between mental health and addiction that's really problematic, and we kind of want to kick it down. So they are doing one-on-one therapy with people sitting in the booths in the OPC. They are doing therapy with people in the garden, or they're doing counseling sessions, cognitive behavioral therapy, tapping, all the different modalities, going on a walk in Washington Heights or in Harlem. They're doing group sessions. They're doing mental health diversion. Because we all know that sometimes when we're using drugs, there are these extreme moments of mood and mind that sometimes can really be dealt with best by some talk therapy, rest, food, care. It does not require police handcuffs in the emergency room. So all of this beautiful diversion work that's happening within our buildings, picking up all of that messy work and putting it down somewhere that is discreet and safe and supportive for our folks.
I wanted to add something very quickly, because I'm sure somebody behind that camera, or some of you in this room are going, so if you're doing that, and they're getting holistic this, and comfortable this, and their feet up, why would they want to stop? Somebody got to be thinking that. So I'm not going to get into whether they should stop or not, but I'm going to respond to that as if I agree they should stop, just for the sake of conversation. Why? Because now they're human. Now they're being treated with some dignity. Like, this is kind of cool. Wow, you're addressing me. We call people by their name. What's the big deal? For our people, it's a big deal, right? So having all those things aren't attached. For them, they don't experience this, oh, I came to this place, I use drugs, that's how they treat me. No, for them it's, wow, even though I use drugs, that's how they treat me. See the difference? But in this defensive, crazy American way of thinking, it's right away, oh, but if they do that, that means that. And every time people say that, I say, do yourself a favor and apply it to yourself. And see if you do it. Example, we had these ads on the subways in New York. And this person from a specific political group didn't like the ads. And it was like, if you use drugs, be safe, don't be ashamed, make sure someone has Narcan, there's all this beautiful messaging. And his response was, oh my God, our 3-year-olds are gonna wanna use drugs. That was his response. And I said, I've been on those subways. And I saw one for breast enhancement. And I didn't decide to go get my breast enhanced. And I'm not 3. I might have the means to do it. Right? But that's that automatic, and people jump in on that. Yes, every 3-year-old's gonna want to use drugs. Like, what? So you know, I ask people to step way back. And let's just get into reality, right? Let's step way back here and figure out, like, stop making these what ifs. And if we weren't being recorded, I would tell you my favorite what if. But, you know, all of these, and all of these scenarios that just are not based on anything but madness in our brains. I've had people from other sections say this is against religion and this is against all this other stuff. And I remind them, I think you're reading the wrong book, right? Because some of the most committed people who are also attached to religion worked with these folks more than anyone else. But we make up stories in our minds that don't apply to the work we do. And Kayla wanted to add something.
You got me going. I gotta say one thing. Yes.
Just real quick. If you have to leave, please fill out the Google form, and also please grab food. There's pizza and food over there. I don't mean to cut you off. This is, we're past 2:30. I know we don't want to lose your input if you do leave. So thank you.
Okay. No, it's okay. I'm sorry. Survival drug use is peak and valley drug use. It's binge drug use, right? So if you don't have a consistent place to use, you're using where you can, when you can, right? Which means you can't plan your use, you can't use safer practices. It's really survival drug use. Oh, I can duck behind this dumpster. I've got about 3 minutes. I don't know when I'm going to be alone next. So you're not dosing in a safe way. It's just really a nightmare. Consistent access to the overdose prevention centers promote stabilization of use patterns and maintenance use. That, in conjunction with all of the other programs we outlined, results in a decrease in use overall, a very significant decrease in use overall. It usually happens around the 6-month mark, and that's exactly what we saw at both programs in New York City. So when you're hungry and tired, what happens to your diet choices? Do you eat better food or do you eat crappy food? We all eat crappy food. It's the same thing with this population. When they're hungry, tired, and sick, they're making riskier choices by providing people rest, food, hygiene services, medical care, and consistent access to a safe place to use, reliable access to a safe place to use. All of those factors combine to actually decrease people's use over time in very significant ways. So I just wanted to mention that, just in case anybody was out there being like, that sounds crazy.
Right, we have time for just a couple of questions, one here, and then Dr. Jasmine, you are our last question.
Hi, I'm Ella. I'm with Above and Beyond Family Recovery Center. I know you.
Oh, there she is.
I know you have two different models. I just wanted to hear a bit more about the differences you've noticed in the models. And you said that the two different sites are different populations that use in different ways. And like, do you think those models work specifically with each site because of that, or could they be switched?
I really appreciate that question. So when thinking about where to house the peer or consumer-led model, the Washington Heights program really made the most sense. We didn't really get into this too much, so I'll go over it very, very quickly. Of the 1,600 registered users, the vast majority are in Harlem. It's the Washington Heights cohort is quite small. It's around 400-ish, maybe 500, with over 1,000 in Harlem. The Washington Heights cohort is, the average age is 29, with some real gray hairs pulling up the average on the other end, and some real young folks pulling it down. They're really young. All speedball injectors, so multiple syringe injections multiple times a day. Speedball, if anybody doesn't know, is a stimulant and a depressant, typically heroin and cocaine. If we know that fentanyl is proliferating through the entire drug supply, and we know that to do a speedball, most speedballers prefer to inject their stimulant and their depressant separately, so that's 2 injections, and we know that fentanyl is also in the cocaine, that population has the opportunity for overdose, sometimes 24 times in a 24-hour period. These guys are injecting multiple times an hour, sometimes, or at least once every 2 hours, using multiple syringes. So, of the 434 overdoses, the majority are in Washington Heights with that much smaller cohort. So, high-risk population in terms of age, high-risk population in terms of drug choice, and high-risk population in terms of modality. Having that as the consumer-led or peer-led model made a lot of sense because of the way young people move. They like to talk. They're a little bit less inhibited, right? They're more community-based. They tend to use in cohort more. So one of the things that we're looking at is, what does it look like in terms of readiness for further care when the people offering you further care are from your community? So those factors of comfort, relatability, et cetera, et cetera, et cetera. The Harlem program, the more traditional medical model, interestingly, when we launched, it was that cohort who was like, this is disrespectful to be using out in public in front of everybody else, because they're older. Right? That longer, more years with that stigma around their use, whereas the young cops were like, okay, this makes sense. Of course. The old guys in Harlem we had to work with them a lot in terms of being in the booth and being observed and sort of revealing that side of themselves. So it made sense, again, in that situation to have that higher threshold of care, a slightly older staff, et cetera, et cetera. So that's why we chose the models that way.
All right, last question.
So you said that 3 times.
Last question, really.
Hi, my name is Dr. Jasmine. I'm with Chicago.
It's Dr. Jasmine.
And one question I had when you talked about the relationship building you did with your local police department, that raised a question in my mind. Do you have a relationship that's forming with your local DEA agency? Because they also regularly test drugs, and in an ideal world, they would alert you when they find an increased concentration of fentanyl in any substances they have.
That's so interesting. We never talk about that.
The DEA?
But Kaylin brought this up a lot in the beginning. What about the DEA? What about the DEA? And what we got was like, we're working with the city. They don't really talk to the DEA. The blessing has been with the feds across the board. They've nicely minded their business. It was Kaylin gave me nerves one day. I don't know what it was, like a few weeks after we opened. Like, we didn't talk about the DEA again. I was like, oh no, DEA. Like, all of a sudden. But the reality is, different administration, different look. We know they're peeking in. We know they're checking in and wondering what's going on. But sometimes you don't kick a sleeping dog. And so they've been nicely quiet. We're getting some really good feedback. I gotta be very careful here. We're getting some really good feedback on the federal level. What I can point out is one of the mistakes we made as harm reductionists is when Joe Biden mentioned harm reduction, people started dancing in the street like we won. And that's 20 years late. So let's not celebrate that. That's a mistake we make in communities as well. They give us something years later and we think we won. What I consider more victory is Rahul Gupta referring to OPCs. Now that's very different. That took that conversation of harm reduction and him saying OPC way to a completely different stratosphere. So we're excited about this, and I want to add something else. Please don't get confused by the safe house ruling and the crack house statute. Many people believe that if safe house wins their lawsuit, that all of a sudden we can all open. It just doesn't. I hope it does, that'd be nice. But no one has ever said officially that if this rule is passed, automatically there's no more crack house statute. There's nothing to do with the other. So we have to be very careful around that. It's a very long answer to the DA's been quiet. We don't talk about them. We leave them where they are. Oftentimes the DEA does talk to the local precinct before they make a move anyway. And that's a blessing for us because our relationship is amazing. The continued communication with them inviting us to meetings, community meetings, and what they call build a block, and getting us involved. The mayor coming to visit, spending time with us, tweeting after his visit, telling us we need to be open 24 hours, pushing to possibly making sure he adds some of that opioid settlement money that they receive specifically for us. These are all things that are going in our favor.
Can I add one tiny thing?
Yep.
So we, as Sam mentioned, so it seems like I'm learning something. Apparently I was more preoccupied with the DEA than Sam, apparently. But, we were thoughtful before we went, right? As the provider, we are incurring all of the legal risk. And I want to say very loudly for the record, we do not have state permission to operate or federal permission to operate, and we are operating like crazy. So we looked at Safe House. So Safe House was under Trump. They didn't have sites built, they didn't have policies and procedures written, they didn't have staff trained, they hadn't been operating an unsanctioned program for 6 years, which we were at both sites. And they were issued this cease and desist letter from DOJ that essentially said, stop everything you're doing, and we need demonstrated proof that you've stopped everything you're doing within 6 months. It was a letter. So our policies and procedures and some pictures of our sites as they were being built were leaked at a certain level at the ONDCP and even at the DOJ to see if anything, not too high, but high enough that they're going to be taken up. So we have reason to believe they know what we're doing, what they definitely know now. I don't think there's a person in America who doesn't know now. But 109,000 people died from overdose deaths last year, coming after the only 2 OPCs in the country that are trying to put a dent in that is not a cute look right now. And as Sam said, there is lots to signal that DOJ and the feds are headed in the right direction. And, you know, we can't get into details, but we've hosted over, I really think it's like over 200 some odd tours. And, you know, that's all I'll say about that, but just know that the people who need to be learning about this are learning about this, and that's very, very encouraging. Yeah.
Let me just say this about the crack house statute, because I think you're gonna write it. I believe he's gonna repeal it. I really believe he will.
You're gonna write it, right?
I really
yeah,
believe.
she's gonna write it.
I don't just bring it up as a part of a conversation. And, you know, I heard Kaylin said they're moving in the right direction. I really believe it's going to happen. I do. I think, you know, part of the excuse the United States has used is, well, that's other countries. We haven't had it here. We don't know what's going to happen. That's off the table. And I think the biggest impact for those who make up stories about what's going to happen when we open, which none of it happened, the negative stuff, is now they see it, they realize it's not as big a deal as they thought. They realize the community's cleaner. They're hearing positive feedback from real community members, not staged folks. And they're like, you know what? They also like that $13, $14 million saved in 8 months. It's a lot of money, right? So $3 million to make maybe $30 million by the end of the year, that's pretty good. So I really believe that Rahul Gupta and Joe Biden will figure it out and hopefully not take the political approach, Newsom in California, and do the right thing.
Wow. Okay, thank you for everybody. Thank you for the questions. I really want to push the food. And make sure you fill out those blue forms. And can we all give another hand for being here?